Greetings, doctor and friends. So we are from SGD B5. Will present about the critical appraisal of apolipoprotein A1 and B levels and the risk of ischemic heart disease during a 5-year follow-up of men in the Quebec cardiovascular study. So these are the members of our group. So let me introduce myself. My name is Gusti Adi Afza with the last 30 12. So for the introduction, I will explain about the background of the study. The cardiovascular system consists of the heart and the blood vessels, and one of the diseases that affects the cardiovascular system is such as the coronary artery disease, which is a non-communicable disease. This disease can be caused by the blockage of the blood vessels by the atherosclerotic plaque and can eventually cause the ischemic heart disease or the IHD. And in 2016, this non-communicable disease contribute to the 49 million death cases worldwide, or can be said 71% of the total death cases worldwide. And around 17.9 million cases is due to the cardiovascular diseases. And the World Health Organization estimated that the 9 million cases of them is due to the IHD. And many things can be the risk factors of the disease, or the non-modifiable factors such as the age, sex, genetics, family history, and for the modifiable factors such as the BMI, DMT type 2, diabetes mellitus type 2, smoking, hypertension, dyslipidemia. And the hypercholesterolemia, such as the form of the dyslipidemia, can be predicted from the levels of the low-density lipoprotein or the LDL and the high-density lipoprotein or HDL. So the increased LDL is considered to increase the risk of the CAD, while the increased HDL will decrease the risk of the CAD. Therefore, the ratio of the LDL and HDL is considered to be a predictor of the severity of the CAD and the incidence of the IHD. And the level of the LDL can be assessed from the apolipoprotein B, and for the HDL, it can be assessed from the apolipoprotein A1, a component of protein of the HDL. Therefore, a critical appraisal based on the evidence-based medicine is needed to determine whether of these parameters are better as a predictors of the IHD. So that's all from me. Thank you.
Hello, my name is Geraldine Gutama with the last 3 digits of student ID 100, and I'm going to talk about the current risk factor. So the first term is atherosclerosis. It is a chronic inflammatory disease, which is caused by a plaque that narrows and hardens the arteries, and the plaque itself made up of lipids and inflammatory cells. Next one is coronary artery disease or CAD. It is a plaque that build up in coronary arteries and then reducing the blood flow to the heart and causing angina or heart attack. And next one is ischemic heart disease or IHD. It is a syndrome due to poor blood supply to the heart and causing angina, myocardial infarction. And atherosclerosis itself is an underlying cause of CAD and IHD. For the current risk factor, it is divided into two, behavioral and biomedical. And for the behavior one, it is consisting of unhealthy diet, physical inactivity, and smoking. And for the biomedical, consists of hypertension, dyslipidemia, diabetes, and obesity. That's all from me. Thank you.
Hello everyone, my name is Nyoman Satya Mahayana Putra. My registration number is 050. Today I will explain about the pathophysiology and diagnosis. CAD primarily occurs due to atherosclerosis, where plaques made of lipids and inflammatory cells build up in the coronary arteries. This process begins with endothelial injury, triggered by factors like hypertension, high cholesterol level, and smoking. Over time, these plaques grow, causing narrowing or blocking of the arteries, which can lead to acute coronary symptoms like heart attack. Moving to the diagnosis, patients with CAD often present with angina pectoris, which can be stable or unstable. To confirm the diagnosis, we start with non-invasive tests like ECG, stress test, or CT angiography to assess heart function and arterial health. In more complex case, invasive coronary angiography is considered to as the gold standards for visualizing blockage in arteries. The advance in this method has improved diagnosis accuracy and allowed better assessment of patient risks. Finally, for the result in the patients, UV marker are used, especially high sensitivity troponins allow us to detect myocardial injury at very early stage. Advanced imaging tools like cardiac MRI and PET scans now provide detailed view of myocardial perfusion and viability. These advancements help us detect CAD earlier and tailor treatment strategies to individual patients, ultimately improving outcomes. That's all from me. Next.
My name is Davin Tadeo with the last three digit number 099. Okay, I'll discuss the current therapy of coronary artery disease or CAD, which has evolved significantly with a focused on individualized management to improve the outcomes, lifestyle modification, and revascularization tailored to the severity and the clinical of the disease. Pharmacological strategies play a central role, including antiplatelets agent, lipid-lowering therapy, renin-angiotensin system blockers, which together reduce the cardiovascular risk and improve the prognosis. For patients with the persistent dyslipidemia, despite standard treatment, novel approaches such as PCSK9 inhibitors are now recommended. And the tools guide revascularization decision and improve the patient outcomes. Early intervention in coronary syndrome significantly reduce mortality, but long-term prognosis depends heavily on secondary prevention, including strict control of risk factors like diabetes and hypertension. Despite the advances, CAD, a leading cause of morbidity and mortality, underlying the need for ongoing research into innovative therapies and preventive strategies. Thank you. Thanks.
First, let me introduce myself. My name is Febryano Adi Prawira with the last three digits of my SPN number 156, and I'm going to explain about foreground questions and clinical research questions. Before I get to the foreground question and clinical research questions, we can read the scenario here on the screen. So based on the scenario, we can make our foreground question, which is apolipoprotein B a better predictor of ischemic heart disease or IHD compared to ApoA1 or apolipoprotein A1? Next, before we make our clinical research question, we need to make a people frame which consists of four components. The first one is P, problem or patient. In this case is adults. Next is I, which is indicator. This can be apolipoprotein B or its synonymous term, which is ApoB or ApoB. Next is comparison, which can be ApoA1 or its synonymous term, which is apolipoprotein A1, apolipoprotein A-1, or Apo-A1. Next, is the outcome, which is ischemic heart disease, or its synonymous terms, which is IHD, CAD, or coronary artery disease. And based on the PICO frame, we can make our clinical research question, which is in adults with or without risk of EHD or ischemic heart disease, is apolipoprotein B a better predictor for ischemic heart disease compared to apolipoprotein A1 or ApoA1? That is all from me. Thank you.
Hello, my name is Sheila Caroline and my last digit number is 016. I will explain about the validity aspect of the critical appraisal on this research. So in this article, there are several aspects of validity that can be evaluated. First, the study used a sample of 2,155 men aged from 45 to 76 from the Quebec Cardiovascular Study. So these participants were examined for cardiovascular risk factors. The sample was large enough to ensure reliable results, but since only men were included, the findings might not apply to women. Secondly, the study used independent reference standards to define ischemic heart disease, such as clinical diagnosis and medical records. So this ensures the result were not biased by the apolipoprotein levels, keeping the outcome measurements still objective. And third, the study measures apolipoprotein levels and ischemic heart disease outcomes using scientifically valid methods. Although the study didn't mention if the outcome assessment was blinded, but the use of statistical analysis helped control for confounding factors, making the results more reliable. That's all from me. Thank you.
Hello, my name is Gusti Agung Saraswati. My last reads number 056. For the study used standardized technique to measure apolipoprotein levels and ensure reliable and consistent result. However, it did not provide detail about variability between labs or quality control, which is elimination. Fit, the findings were not tested in a separate group, which limits how widely they can be applied. Future research should repair the study with different population, include women and people from other regions to confirm the result. That's all from me. Thank you.
Hello everyone, my name is Gregorius Thongiratama with last three digits of student number 85. Now I'm going to explain about the important aspect of critical appraisal. So the article clearly explains possible causal relationship in biomarker selection, as the researcher explicitly mentioned ApoB as crucial factor in secretion of VLDL and associated with triglyceride metabolism. Then it is also related with denser LDL particles, with heightening risk of IHD. For result precision points, we highlight some results that were not statistically significant, with confidence intervals value exceeding 1, despite being clinically meaningful. For instance, is elevated ApoB levels with a reduced total or HDL cholesterol ratio with 95% confidence interval range from 0.8 to 3.0 and elevated ApoAI levels of 0.85 relative risk with 95% confidence interval range from 0.70 to 1.03. The study already used appropriate methods for result analysis, including usage of Kaplan-Meier, students t-test, chi-square, and multiple linear regression. That's all from me. Next presentation will be continued by my colleague. Thank you.
My name is Anjani Prabandani Sudewa with last three digit 148. I will explain about the important aspect. The study included 2,155 men aged 45 until 76-year-old who were followed for 5 years. Results show that 116 participants developed ischemic heart disease during the study period. Kaplan-Meier analysis showed that participants in the top delta of apolipoprotein levels were less likely to be free of ischemic heart disease compared to those in the first tertile. There was no significant difference in the incidence rate of ischemic heart disease between tertiles of apolipoprotein A1. Multiple proportional hazard model analysis also showed that the association between apolipoprotein levels and ischemic heart disease risk remains significant even after control for other risk factors such as triglyceride, cholesterol, and total cholesterol ratio.
My name is Natania Faustine Santoso with the last three digit number 158. The study on ApoA1 and ApoB as prognostic markers for ischemic heart disease provides valid and important evidence that could be applicable to patient care under certain conditions. The research, based on middle-aged men from the Quebec Cardiovascular Study, demonstrate that ApoA1 and ApoB levels are significant predictors of IHD risk over a 5-year period. While these findings are robust, their applicability depends on the similarity between the study population and patients. If the practice includes population with differences in gender, age, ethnicity, or baseline cardiovascular risk factors, the results may need cautious interpretations. For instance, the study's focus on men may limit its direct relevance to women or other demographic groups. Next.
Hello, my name is Eyn Awdy Afza with last three digit number 102, and now I will continue the presentation. Okay, I will explain about I will do the critical appraisal about applicability aspect, and I will answer the question about will this evidence make a clinically important impact on your conclusion about what to offer or tell your patient. Despite this potential limitation, the evidence has the potential to make a clinically important impact on patient care. Incorporating measurement of ApoA1 and ApoB could improve risk stratification. identifying high-risk individuals who might not be detected using conventional lipid profiles such as LDL and HDL cholesterol levels. This biomarker provides a more precise assessment of cardiovascular risk, which could guide personalized intervention. For patients with elevated ApoB or reduced ApoA1 levels, clinicians could implement more aggressive lipid-lowering therapies, lifestyle changes, or targeted counseling to mitigate the risk of IHD. Additionally, biomarker-based risk assessment can enhance patient understanding of their cardiovascular research, fostering greater motivating for preventive measures. However, the utility of this evidence also depends on the availability and cost-effectiveness of ApoA1 and ApoB testing in the clinical setting. If this biomarker can be integrated into routine practice without significant logistical or financial barriers, they could substantially improve patient outcome. Overall, this evidence support a more tailored approach to managing cardiovascular risk, though its practical adoption requires consideration of patient characteristics and healthcare resources. Thank you. That's all from me, and the next will continue by my friend. Thank you.
Hello doctors, my name is Nevinne, Natania, Susanto, and the last three digits of my student number is 051. Now I'm going to explain about the results of this critical appraisal. According to the article, ApoB had the strongest correlation to IHD. It can be considered an important first factor for developing heart diseases, including atherosclerosis. Based on the critical appraisal, we can conclude that this research is valid. It is important to discuss with the patient regarding the significance and interpretation of the results of both traditional and novel biomarkers, and also to take account of the clinician's level of expertise when selecting which biomarkers to be used. The integration of the study's results with clinical expertise and the patient's values can lead to the implementation of an effective assessment of IHD risk, particularly in men. That is all from me. Thank you.
Okay, thank you for the time. My name is Nyoman Sujana with last three digits of student number 011, and I'm going to summarize our student project. Next slide, please. Based on the article that has been reviewed by our groups, it can be concluded that apolipoprotein B may be considered a relevant predictor in the assessment of coronary heart disease risk in men, compared with apolipoprotein A1. Foreground questions and clinical research questions can also be generated based on the reviewed articles. According to the critical appraisal aspects, the article has fulfilled the three aspects, namely validity, importance, and applicability. However, several things need to be underlined, either the need for validations of findings in independent groups or their application, which needs to pay attention to patient characteristic and health resources. I think that's all for me. Thank you.